Thank you. You heard of Mohammed Salah, the player, huh? Liverpool. So we have also, you have a Professor Mohammed Salah here, cardiologist with us from Kalba. And it's great to have him, really. He's a friend and colleague. He's going to talk to us about SGLT2 inhibitors, when and for whom. Professor Mohammed.
Okay. Good evening, everybody. Thank you so much, Dr. Abdallah, Dr. Rosano, for inviting me to this prestigious course, educational course. Actually, my presentation now, I think it will be easy after we heard from all previous speakers. So I will try to just make as a review or sum up of what we heard. So this is my declaration of interest. As we know, the heart failure, it is has so many burden worldwide. As we know, number of patients in heart failure is 21 million adults worldwide are living with heart failure, and the number is expected to be rise. Moreover, 50% of heart failure patients die within 5 years from diagnosis. And the rehospitalization, the heart failure is the number one cause of rehospitalization for patients aged more than 65 years. Moreover, the comorbidity that associated with heart failure, as we know, the majority of heart failure patients has 3 or more comorbid conditions. Of course, this will lead to affect the economic burden. In 2012, the overall worldwide cost of heart failure was nearly $108 billion. So what are the goals of treatment of any heart failure? 3 important goals that we have to look at for it, and it's any drug used in treatment of heart failure, we should get the benefit of all these 3 points. First of all, improve the clinical status, functional capacity, and the quality of life, prevent hospital readmission, and we have to reduce the mortality. Again, we have what we call the cardiorenal metabolic system. We should always don't forget the cardiorenal metabolic system. Why? Because the cardiorenal metabolic system are integrated. Any acute or chronic dysfunction in the heart, or kidney, or metabolic system may induce dysfunction in the other. And each dysfunctional organ has the ability to initiate and perpetuate the disease in other organs through hemodynamic, neurohormonal, and immunological biomarker feedback pathway. And as we know, type 2 diabetes is a risk factor for disease related to the cardiac and renal system. This is the heart failure, new heart failure classification. As we know, there is heart failure reduced ejection fraction and the mild reduced ejection fraction and heart failure preserved ejection fraction. And you are going to do the journey of all these type of heart failure with the SGLT2 inhibitor. SGLT2 inhibitor, it's a very nice group of drugs that has been recently introduced worldwide. And as we can see, it changes the guideline. But the interesting point is that no one till now know what are the mechanisms of action of SGLT2 inhibitor. However, there is so different mechanism, and one of the postulated mechanism is the SGLT2 inhibitor increase actin through inhibition of SGLT2 and proximal and the distal convoluted to proximal tubule, which lead to increase glucose and sodium excretion, and this of course lead to decrease the natriuresis and diuresis. One of the 2 important trials, as we heard on all previous speakers, that lead to change in the guideline for SGLT2 inhibitor, what we have the EMPEROR-reduced and DABA heart failure. And I'm showing in this slide the difference a little bit in the characteristic of the baseline of the patient in both groups. As we can see, in the EMPEROR-reduced heart failure in comparison to DABA heart failure, most of the patients, they have more than reduced ejection fraction, higher NT-proBNP, and plus they have more impairment in the kidney function. So they are very high risk in favor of EMPEROR-reduced and empagliflozin in comparison to dapagliflozin. And as we can see, this is in the DABA heart failure and empagliflozin-reduced. We can see that the primary outcome in both trials, there is significant reduction in the primary outcome in the term of cardiovascular death and hospitalization for the heart failure. And there is a significant reduction of the hospitalization for the heart failure and cardiovascular death. So both trials show the benefit in reduction of the primary outcome in patients with heart failure, with or without type 2 diabetes. And as we can see, this is from Canadian Cardiovascular Society. In this trial, dapagliflozin and EMPA respectively significantly reduce the combined endpoint of cardiovascular death or heart failure hospitalization compared to placebo. Mind you, again, the difference in the trial relate to the baseline characteristic of the patient. The EMPEROR-reduced patient have higher risk and more reduced ejection fraction and the more aggressively treatment with heart failure therapy. And disease magnitude, again, observed in post-trial similar in patient with or without diabetes. This is a meta-analysis also from post-trial, and they showed that in post-trial there is significant reduction of all-cause deaths in post-trial. Again, also there is significant improvement in the renal function. And as we can see in the embryo-reduced and DAB heart failure, at the beginning, in the small initial, there is small reduction in glomerular filtration rate. But if we look to the difference between the two curves in favor, we can find that there is significantly in favor of empagliflozin and the dapagliflozin in comparison of the conventional therapy. In patients with chronic renal impairment, they decline or reduce or regress the reduction in the renal function. This is again showed that the embryo-reduced and double heart failure, the renal endpoint, and as we can see, there is improvement of the renal function or delay or the decrease in the progression of the renal decline or renal declining function, but more in favor with empagliflozin than dapagliflozin. This is again another meta-analysis that we can show that we got all the benefit either in patient with or without diabetes mellitus, which is a very important point and the more interesting point about the SGLT2 inhibitor. Somebody says that again, what we happen, maybe the benefits that we got from this trial because that we have an ARNI introduced in this post trial. But as we can see here, the meta-analysis that we use both EMBA and DABA with or without ARNI, and we can find that the benefit, we got benefit also without using the ARNI. However, there was an additive effect when we add both of them together, as we can see here, ARNI and SGLT2 inhibitor, the two drug classes added incrementally to each other. And they can and they should use together, and the adverse reaction profile are and the mode of action are complementary for each other on many, and one may enhance the tolerability of the other. And actually, one of the importance of the SGLT2 inhibitor is that when you introduce, this will allow you or facilitate to introduce the ARNI or ARBs to treat patients with heart failure. And we shouldn't forget that the cardiovascular effect of SGLT2 inhibitor, this is a nice meta-analysis also. As we can see, there is reduction of MACE, the composite endpoint, also reduction of heart failure, hospitalization, and the cardiovascular death, and reduction of hospitalization of heart failure. So, as we know that the SGLT2 inhibitor, they can use be as an anti-failure medication now, plus they are cardioprotective drug through reduction of MACE. What about the quality of life? As from this slide, we can see that all of the SGLT2 inhibitor, they associated with the improved the quality of the life. And we can see that in embryo-reduced showed comparable effect to the imperial-reduced and the dapagliflozin trial. So they are reduced improves the quality of life of the patient with heart failure with reduced ejection fraction. Recently, and of course you're going to hear from Professor Anker about the embryo-preserved that we recently published, that the effect of empagliflozin and cardiovascular death and heart failure, and the SGLT2 inhibitor EMBA shows that the 21% risk reduction for endpoint of cardiovascular death or heart failure hospitalization. Plus, the rate of decline in glomerular filtration rate was slower in patient in the EMBA group compared to patient in the placebo group. What is the importance of this study? Because this was considered the first study that addressed the heart failure with reserved ejection fraction since more than 18 or 20 years, and we have an significant endpoint. So now we can ask our question, for whom we prescribe the patient with SGLT2 inhibitor? As we can see, across the whole range or whole spectrum of heart failure patient, we get benefit in heart failure patient with reduced ejection fraction, heart failure patient with mildly reduced ejection fraction, and heart failure patient with preserved ejection fraction. So this is for whom, plus the previous indication that we can use on a patient with type 2 diabetes, very high risk type 2 diabetes, plus we have cardiovascular disease. So this is for whom now we prescribe. We have a broad indication to use SGLT2 inhibitor in patient with or without type 2 diabetes. So if we get the benefit of SGLT2 inhibitor, this slide summarizes what we have the benefit. It's produce, cause reverse cardiac remodeling, improve heart failure symptoms, reduce the heart failure hospitalization, and they are protect the kidney. And if you remember, we said from beginning, what is the aim of the treatment of the heart failure? To have all these beneficial effects. So how can we start the SGLT2 inhibitor? Usually, now suppose that we have a patient on triple therapy like ARNI or beta blocker MRA. The good point about the SGLT2 inhibitor is that you have a single dose. You start with single dose. No need for titration required. The target dose of other drug not required before adding SGLT2 inhibitor. On contrary, this will facilitate that you can introduce the other group of drug, because now we are in the era of use the all combined 4 drugs together. Now we are not in the sequential therapy, we are in the combined therapy. And another good advantage that you're not to worry about to monitor them. Why? Because they have little effect on the blood pressure, counsel patient on risk for mycotic genital infection. However, don't need to reduce or to stop the diuretic dose. You just need sometimes to consider adjust in diuretic dose. So this is a practical issue, a practical point when to start the SGLT2 inhibitor. Again, from the clinical perspective, one of the easiest agent now to be added to existing medical therapy, and they can be used even in patients with new onset heart failure. In general, don't reduce the diuretic dose like is done when starting with ARNI. This is usually we are suffer a little bit. You have to reduce the dose because when you start ARNI or ARBs, okay, and they provide education to the patient about the possible increase in diuresis. So again, how can you use SGLT2 inhibitor? I'm combining all the indication. Patient with type 2 diabetes, cardiovascular disease, with glomerular filtration rate more than 45 in EMBA or 60 in DABA, and it choose the SGLT2 inhibitor EMBA 10 milligram as a starting dose or DABA 10 milligram, and be cautious about the insulin and stop DPP4. However, in heart failure with reduced ejection fraction without type 2 diabetes, usually to initiate the EMBA 10 milligram or DABA 10 milligram. So what are the contraindication or cautions? The contraindication for this drug, it's not approved for use in patient with type 1 diabetes due to increase the risk of diabetic ketoacidosis, patient who has known hypersensitivity to drug, patient has lactation or in dialysis. Can be used in cautious in some patient with heart failure care where dapagliflozin with glomerular filtration rate less than 30 milliliter per minute. This is very important. For heart failure patient with EMBA, that glomerular filtration rate now reach up to less than 20. As I told you, this is the advantage of also of EMBA over DABA, because you can use it for more patient who has more impaired kidney function during pregnancy, and always take care during the patient has ketoacidosis. In patient with diabetes, you have to make temporary discontinuation of this drug because they increase the incidence of ketoacidosis. Is not too much common effect, but you have to be cautious about this point. So what are the guidelines and the clinical practice tell us? We know now from all the previous speaker and from coming speakers that this is a Canadian Cardiovascular Society, and they recommended to use SGLT2 inhibitor plus the other all the drugs that we can use, MRA, beta blocker, ARNI or S inhibitor as a step 1 indication. So they are indicated now as a class 1A or step 1 to be used Canadian Cardiovascular Society. Even sometimes they said you can start with them before to start any drugs. Then the end is a latest guideline in ECC. As you heard, they are class 1A indication now. Either DABA or EMBA are recommended in patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. Also, don't forget before, in the 2019, the European Society Cardiology for Management of Type 2 Diabetes, that they are indicated as class 1A for patients of type 2 diabetes with high risk or very high risk to develop cardiovascular morbidity and mortality. And EMBA, it was class 1B recommended in patients with type 2 diabetes and the cardiovascular risk to reduce the risk of death. This, of course, comes from the EMBA outcome trial. You know it very well. So to summarize and to make what we hear now about the SGLT2 inhibitor, they are easy to use. Why? They have few contraindication, single dose, no need for titration, minimal effect on the blood pressure, on the heart rate, and renoprotective and longer term. They associated sometimes with a small decline in glomerular filtration rate upon the initiation of the therapy, secondary to change in intraglomerular pressure. But in longer term, as we saw from both trials, that they improve the renal function. So in summary, the treatment of heart failure reduced ejection fraction now is evolving. There is new clinical practice documented are available to help supportive physician like Canadian Cardiovascular Society, 22-1 update on 2017 ACC expert consensus, recent guideline from European Society of Heart Failure. Available clinical practice recommended foundational therapy in the majority of patients with heart failure with reduced ejection fraction, ARNI or ARBs, beta blocker, MRA, and SGLT2 inhibitor. Use of additional therapy can be individualized based on the patient phenotype. Then, thank you so much for your attention.
Thank you very much, Dr. Mohammed. Now, SGLT2, you know, there are 5 of them now. There are 5, and 2 of them are into the heart failure. So I mean, and lately, of course, in the HFpEF and still not in the guidelines. How many of you got experience of using SGLT2 in heart failure purely without diabetes? Right. How do you convince your insurance? What do you tell them? I mean, because at the moment you have a problem with that. Anyone wants to? Sharif, yalla. You used it. Come on, tell us how. Give us a secret.
The secret is most of them, they have pre-diabetes. I mean, they are obese with pre-diabetes. So it's very easy to convince the...
Okay, this is what I do actually, but you know, any other way you can?
Yeah, I mean, we always, we also used to do that before it was commissioned by NICE, and we were doing oral glucose tolerance tests, because with that we could unmask another 30%, 40% of patients who were eligible for that. So I think that is, I mean, for us to be honest, for myself, for Gianluigi in Europe, it's not an issue, because it's everything is paid for. So it's, but we understand that in other areas can be an issue. But what is important is that they're not too expensive.
Exactly, yes. I mean, compared to other medication, yes, and easy to take. Yeah, yes, doctor, go ahead, please.
If the patient is already taking SGL type of medication for diabetes, and then they develop CHF, what do we replace? What do we do? If the patient is already on diabetic medication for this type, and then they develop CHF, do you switch the type of SGL that you're using?
So you mean that the patient is already, and we use the SGLT2 as type 2 diabetes,
Exactly.
and they has developed heart failure.
Right.
Okay, so
Do you keep them on the same medicine, or you switch them to
no,
different
you
type?
will start to add the other medication for an anti-failure medication. You already have the SGLT2.
So you keep them on the same?
You keep it the patient on the SGLT2 because you get the benefit now with this for patient. And plus, you add the other group of the drug to treat the heart failure.
Could you please talk to us again about the timing of starting those 4 types of medication? It's still not clear to me the time when we start each one, or like the sequence.
Maybe Professor Rosano, you want to?
Dr. Rosano will ask you, will answer you.
Yeah, basically, regarding your first question, I agree, you continue, but you continue only if they are taking dapagliflozin or empagliflozin. If they're taking any of the others, then we have evidence, once they have heart failure, that only dapagliflozin and empagliflozin are effective. So I would, if they are on, say, on CANA or ertugliflozin, I would switch them into either empagliflozin or dapagliflozin.
We are used
DAPA or yes. Now, regarding starting, they've shown a couple of times the algorithm. Basically, you start all the drugs together. Most patients are already on some of those medications because they have underlying ischemic heart disease, because they have hypertension, or for other reasons. So you just be sure that they get the 4 drugs at very low dose. Then, according to whether they are in atrial fibrillation, whether the blood pressure is maintained or is low, or the heart rate is low, then you decide which one to up-titrate. Let's say you have a patient that has a heart rate around, say, 68, and a blood pressure of 110. I would probably prefer to increase the ACE inhibitors or ARNI rather than the beta blocker. Then if I have a patient otherwise that has, say, impaired renal function, but then an heart rate around 72, 73, and a blood pressure of 110, then I would probably prefer to increase the beta blocker. Then the other thing, what becomes complicated is when you have a patient with an ischemic origin, because in those patients, the threshold for blood pressure should be higher, because in patients with ischemic heart disease, we don't want to have a low mean blood pressure. And therefore, we have to keep the blood pressure, the systolic, above 120. So using that type of adjustments, then you can adjust. But what we can suggest, our suggestion is to start with all of them at low dose, and then look at the different profiles. And in the paper, in the position paper of the Heart Failure Association, is clearly specified for each phenotype on how to implement the different drugs.
How does the treatment change if the patient is almost asymptomatic versus symptomatic?
Now, if the patient is asymptomatic, it depends whether it has, say, elevated BNP or NT-proBNP. Because if it's asymptomatic, the NT-proBNP is moderately low. I would go for control of risk factors. What's your experience?
For asymptomatic patient?
Asymptomatic.
Yeah, I mean, for asymptomatic patient, usually I can start the medication also, just to be sure that there is no progression can occur for the case.
Yeah, I mean, this classification A, B, C, D for heart failure is interesting because you need to work on prevention. And these are the asymptomatic people. You know, patient with hypertension, diabetic, you should consider them. These are at risk of having to start. I mean, SGLT2 now is everywhere, and how simple it is to be used, as you heard from Dr. Mohammed. Now, the question I have for the expert here, we have SGLT2 with outcome trials, 2 of them. But we see patients already with diabetic, already on the other SGLT2. Now, if they developed heart failure, as the doctor said, are we going to change them to the one we have with evidence, or you keep them with that one?
No, and I think
we have with IMPA, with DAPA.
Yes.
Heart failure outcome with diabetes, but with others we don't have.
So you mean that the patient is diabetic on heart failure and
on other SGLT2, مش IMPA ولا DAPA, the other SGLT2. Will you change it to this one, to the IMPA or DAPA?
I will follow the evidence-based, because our experience, or the worldwide experience that comes from, for the time being, for the IMPA or DAPA. So I think it's better to change to the ones that we have evidence, at least. So that's my suggestion. I don't know, Dr.
I entirely agree. In diabetics, there is also evidence for sotagliflozin, although the study was had all the adjustments because of the COVID situation, but the soloists demonstrated efficacy. But for sure, if they are on canagliflozin or ertugliflozin, I would change for dapagliflozin or empagliflozin, no doubt.
And patient now admitted with heart failure, and you know, and guidelines tell us to start patients on these 4 medication, and SGLT2 very easy to do. Will you do that in hospital based on the SOLOCIT trial, which is small, or you do it within 1 week or 2 weeks? What's your experience?
I mean, the experience, at least, is that if you don't start them, then they won't get started by the GPs. So it's better to start all the medications that you can at discharge. And as it's shown before, basically they have an almost neutral effect on blood pressure. Yes. So you can see the decrease in blood pressure, but only in those patients with high blood pressure. In those with low blood pressure, you don't see any change. So basically, they're very easy to use, and they will make our life easier with all the other medications.
Yeah, one of the other challenges, Dr. Sharif, maybe you want to tell us as well your experience, and others, please, since we are waiting for Dr. Ankar in 2 minutes, he will be with us, and Dr. Mohammed. One of the problems is the renal deterioration. And although we're using this medication to decline the renal, but that's happening, you know. When will you be worried? Anyone? No.
Marco Metro did.
Marco, but we've forgotten, ya akhi. Yani, remind. So,
I would say that, I mean, I would continue the SGLT2 inhibitors until dialysis. There is evidence that, I mean, one thing is the starting eGFR, and the starting eGFR should be above 20. But if they start, that they are already on the medications, and of course the GFR will decline. I mean, until they don't go into dialysis, or continue, because there is also evidence from DAPA-CKD that, for example, patients who received dapagliflozin and they were listed for dialysis at the longer time to dialysis. So there is a protective effect anyway.
If the patient have reached dialysis, according to the data, you cannot use, I mean, it will be off-label, the sacubitril valsartan, and also it will be for the empagliflozin or dapagliflozin. So now, yani what will be, it will be left with beta blocker only and MRA. I think what we'll do now.
Yeah, you're right. I mean, it's the only evidence that the only problem is that if the patient is completely oliguric or anuric, then until we don't get the evidence of other ancillary effects, then we'll have to discontinue and continue with ACE inhibitors, ARNI, MRAs. MRAs difficult, but it's a low dose of everyone. I wanted to ask you one question, and you already covered that clearly on the side effects. But it seems that the side effects that have shown in clinical trials in heart failure were much milder than the ones that have been shown in diabetic patients in the early trials. Is that true?
For the
SGLT2 inhibitors?
The SGLT2, one of the great advantages that it has minimal side effects. See, this is in my experience, because I used to use the SGLT2 inhibitor before to start in heart failure, even type 2 diabetes with ischemic cardiomyopathy and this thing. So these are minimal side effects for this.
So I mean, in HFpEF, Prof, the study which I think will be discussed soon, the side effects, the only significant side effects was genitalia area, not the rest were not there. So it's interesting. You know, we're learning every day something new about SGLT2. But do you know how it works? How it works? I mean, what's the mechanism? Do you know?
The mechanism.
The real mechanism for SGLT2.
The mechanism of SGLT2? Yeah, man, the exact mechanism of SGLT2.
This is all speculation. Yeah. I don't know a real one.
It's not known, but I mean, as I said, this is the active that was the blockage or the SGLT2 in the proximal convoluted tubular receptor, so that will cause this natriuresis and diuresis. As regards to side effects, I think even from the cardioprotective drugs or from all the primary prevention programs, that it was not reported except only for the dapagliflozin, where they said that there is a high incidence of some incidence of fracture that happens with it. But again, it is not.
Yeah. And for the mechanisms, basically, there have been other mechanisms that have been suggested. For example, for empagliflozin, they've shown that there is an increase in the utilization of ketone bodies.
Yes.
So it seems that they work like on the metabolism, like drugs like trimetazidine. And also there's been a suggestion that there is an increased exchange with hydrogen ions.
Yes.
That may have a beneficial effect. But also what is important is that each of us, we are never fasting, except in Ramadan. It's people are never fasting; they always eat, and therefore we always go above our urinary threshold. With the SGLT2 inhibitors, you reduce the urinary thresholds, so you get less peaks of glycemia that translates in less activation of the sympathetic system. So that is another possibility of their effects.
Okay, thank you very much, Dr. Mohammed.